So for our next ACLS case, we're going to talk about adult tachycardia with a pulse. So this patient is going to be more stable than the previous patient we talked about with pulseless activity. So first step, you're going to want to assess the heart rate to see if it is tachycardic. So usually tachycardia we're going to see as being greater or equal to 150 beats per minute. So in this case, in this rhythm shown here, this is an example of SVT, or supraventricular tachycardia. So here the rate is going to be 1 big box, 2 big box. It's about 150. So as we stayed 150 or above, we'll consider as tachycardia. So in this case, we'd first want to maintain patent airways and assist breathing if necessary. Give the patient oxygen if they're hypoxemic, and also begin a cardiac monitor to identify the rhythm, and monitor blood pressure and oximetry. So once this is done, you want to assess certain things to decide whether or not you're going to cardiovert the patient. So first you want to see if the patient's hypotensive, if there's any signs of shock, if there's any acute alteration in mental status, if there's acute heart failure, and if there's ischemic chest discomfort. If any of these are present, then you will conduct a synchronized cardioversion. And if they are not present, then you will ignore that step and not cardiovert the patient. So after those 5 questions are assessed, you want to then look at the EKG and decide if a wide QRS is present, which is defined as being greater or equal to 0.12 seconds. So basically that's going to be if it's greater than or equal to 3 small boxes of the QRS. And in this case, this is actually a narrow QRS, as you can see here, which is characteristic of SVT, usually a narrow complex QRS. So in this case, because it is a narrow complex QRS, you could start off with maybe doing a vagal maneuver, rubbing the carotid, trying to slow down the heart rate. Or if that's not working, you could also then use adenosine. And the dose is usually IV dose, first being 6 milligram rapid IV push, followed by normal saline flush. Then you'll do a second dose of 12 milligrams if required, meaning if the rhythm does not convert to normal sinus rhythm. So if a wide QRS is present, such as in this case we actually discussed this before, this is a EKG of ventricular tachycardia, but previously we were saying the patient was pulseless. So in this case, let's say we have VT in a patient with a pulse, so a QRS greater than 3 small boxes, which you can see here, so wide QRS, you will consider adenosine only if it's regular and monomorphic. So in this case, that you would probably give adenosine, being that this is regular and monomorphic. However, other things you could use are antiarrhythmics, such as procainamide IV. So you'd give them 20 to 50 milligrams per minute until the arrhythmia is suppressed. Also, another thing you could use is sotalol IV, 100 milligrams over 5 minutes. However, you want to avoid this if the patient has a prolonged QT interval, because sotalol can cause prolonged QT.